In this lecture, we will discuss the pathophysiology of ischemic heart disease. Coronary artery disease, which is equivalent to ischemic heart disease, is the most common form of cardiovascular disease. With the advent of primary preventive strategies, such as identifying and controlling risk factors like smoking, lipid levels, diabetes, hypertension, among others, there has been a decline in mortality rates from coronary artery disease. Nevertheless, ischemic heart disease remains the #1 cause of death in most regions around the world. Now, the underlying cause of coronary artery disease appears to be atherosclerosis, not simply from passive deposition of lipids into the coronary artery walls, but also from a chronic inflammatory process within the arterial walls. Furthermore, the greater the inflammation and cardiovascular risk factors, the more aggressive the atherosclerosis and destabilization of that plaque tends to be. And as you can imagine, the greater the atherosclerotic plaque size, the greater the stenosis and the greater the reduction of blood flow through that artery. So if you look here, what we have going on is we have a normal healthy artery in this case, okay, no plaque buildup, and then we have plaque formation in this region here, okay, and then after that you will talk about this thrombus formation in this case, okay, and you can see with this plaque formation we have narrowing of that lumen, okay, this lumen here is becoming narrowed, so because of that we'll have less blood that can get through to the other side, okay, and because of that decreased blood flow we'll see where ischemia comes about. So let's see how this all comes about, okay? Imagine that you have an atherosclerotic plaque in a coronary artery that is continually undergoing some level of inflammation. Now it's the core of that plaque that is composed of inflammatory cells and lipids which drives the chronic inflammation within the arterial wall. The chronic inflammation can destabilize the plaque, resulting in rupture or erosion of that endothelial layer, okay, that's covering the plaque. Consequently, thrombogenic factors may be activated, leading to the formation of a thrombus, which is a process known as atherothrombosis, and then potentially dislodging or obstructing the lumen. This can lead to complete or partial obstruction of the artery and a sudden reduction in blood flow, resulting in myocardial ischemia as well as ischemic symptoms. This situation of plaque destabilization, endothelial rupture or erosion, atherothrombosis, sudden reduction in arterial blood flow, and subsequent myocardial ischemia is referred to as acute coronary syndrome, or ACS. So let's briefly look at this ACS process. So ACS is acute coronary syndrome. So we're saying we first have some atherosclerosis, so deposition of fatty lipids, okay, as well as some inflammation. All right, so if you look here, here's our intima, this is our lumen, okay, in our media, and you have cholesterol buildup, you have these macrophages, and you have an inflammatory process going in there. There's T lymphocytes and so forth, okay. We won't go through the whole process, but there's pretty much lipids, all right, deposition of these fatty acids, as well as inflammation, and as a result, you can have this plaque destabilization, okay. And if you have that destabilization, you can have rupture or erosion of the endothelial covering, okay. So you have usually this endothelial covering, or these cells that overlie, okay, the lipid core, okay, and if you have that, sometimes with this inflammation you can sometimes get a break in that layer, okay, and if you have a break in that layer you can have this thrombogenic factor activation, okay, and if you have these prothrombotic factors you can have thrombus formation, which we call atherothrombosis, okay, and you can see down here, here's our thrombosis forming, okay, we have rupture of that layer, okay, we have these activated thrombogenic factors, and because of that we can have a thrombus that forms, okay. Notice that this is our artery, okay, and notice we have our thrombus forming within it, and because of that it's now obstructing blood flow, all right. Remember the normal scenario with this healthy coronary artery, we had normal blood flow. With this plaque formation we had some stenosis, but the patient is still getting enough supply that is not experiencing any symptoms, all right, unless there's a high demand, and we'll talk about that shortly. However, in this thrombotic phase, where there's a thrombosis obstructing any blood flow, all that muscle that's on this side is not getting any oxygen, and because of that is we're going to have ischemic symptoms that result, okay? So again, thrombus forms, no blood can get to this end, And because of that, we get myocardial ischemia, that sudden decrease in blood flow. Now, just like every other cell of the body, cardiomyocytes require ATP as a primary energy source for cellular functions. Therefore, conditions that increase the workload of the heart, such as exercise, cause an increased ATP requirement in metabolism. With that, there's an increase in oxygen demand for aerobic respiration. However, if that oxygen demand cannot be met due to an inability to deliver enough oxygen to a certain region of the heart from a stenosed vessel, then ischemia ensues. In order to adapt to these conditions, the heart switches to anaerobic metabolism and halts cardiomyocyte contractions. This allows for a reduction in oxygen demand in the heart to endure about 20 to 30 minutes of severe ischemia. This ischemia classically manifests as chest discomfort, which is also referred to as angina pectoris, and is considered the cardinal symptom of coronary artery disease. If the oxygen demand can be met, okay, then the symptoms will disappear within minutes. Okay, and it should make sense that the greater the stenosis, the lower the threshold to provoke these ischemic symptoms. And you can think of this as an oxygen supply-demand balance. Where it may not always be the case from an economic standpoint, we need a balance here. Okay, as the oxygen demand increases, so must the oxygen demand or supply, or ischemic will occur. So you can use these simple balance beams to kind of get an idea of. So imagine this is the normal circumstance, okay? We have some level of demand, meaning, so say you're just walking up the stairs, okay? And there's some demand by you to get enough blood out to the systemic circulation, okay, and to the heart, so you don't have these symptoms. All right, and because of that, we have enough supply getting out and meeting that demand, so there's no ischemic symptoms. Now imagine that we have a patient that has a stenosed vessel, okay, so imagine this is our patient here, and they increase their activity so much, okay, such that the demand increases so much, but we cannot meet the supply that the demand needs, okay, and because we're not getting enough oxygen to the heart in that area, this is where ischemia comes about. Okay, so you have too much demand, and that supply is just not meeting that demand in that case. All right, and we said that what we'll have going on here is that in order to slow down the use of oxygen, the heart will stop contracting for about 20 to 30 minutes, okay? That's like as long as it can go in severe ischemia, all right? And that will reduce the oxygen demand, so for us to get enough supply there. All right, and because of that, that's where we get these ischemic symptoms. Now, if you're able to slow down or decrease the demand, all right, eventually the supply will increase and we'll get a balance, and the ischemic symptoms will resolve, okay? So that's a simple supply-demand, all right? Now, if myocardial perfusion is not restored to that ischemic zone, the cells will eventually infarct, which is considered irreversible cell death or necrosis. The size of the ischemic area or infarcted region has been shown to be correlated with the risk of heart failure, malignant ventricular arrhythmia such as VTAC and VFib, among other complications. All right, let's quickly review what we discussed before we end here. So coronary artery disease, which is this, CAD, is equivalent to ischemic heart disease. Remember, this is the #1 form of cardiovascular disease and is considered the #1 killer worldwide, especially in Western regions, okay? Due to atherosclerosis and lipid deposition is where we get this from, okay? And we also have that inflammation that's going on, right? We talked about the inflammation, and we said that the more aggressive this inflammation is, and the greater the cardiovascular risk factors, the greater risk this patient's at developing ischemic heart disease, okay? Now we said if the plaque size gets greater, the stenosis will increase, and as the stenosis goes up, we get narrowing of the lumen, and we decrease the blood flow to that area distal to that region. Now, acute coronary syndrome, we said we went through this whole process where there's atherosclerosis, inflammation, we get plaque destabilization and rupture of the endothelial layer. Because of that, we get these thrombogenic factors that activate, we get a thrombus that forms, the arterial lumen obstructs, we get a decrease in blood flow, okay, and because of that we get these ischemic symptoms, all right, that develop. Now remember, if just like every other cell in the heart, as we increase the cardiac workload, we need more ATP, okay? And because we need more ATP, we need more oxygen, all right? Now with stenosis, we have a decrease of supply because we're just not getting enough oxygen downstream. Because of that, we can get this supply-demand mismatch, and from that, that's where this myocardial ischemia comes about, okay? And that's angina pectoris, which is reversible if we decrease the demand, allowing the supply to come back up. Okay. However, if perfusion is not restored, this is where we get that infarction or an MI, and that's necrotic tissue, cardiac tissue that is damaged so bad that it's irreversible, okay, and can't come back to life. Now, we said that the greater the ischemic size or the infarct size, whatever it is, has a proportion that's directly related to the increase in heart failure, these arrhythmias such as VTach and VFib, among other complications. Well, that's the end of this lecture. We discussed the pathophysiology of ischemic heart disease. I hope you learned something.